Hi, and welcome to the MedTech Insider, your inside look into all things med device. My name is Parker Snedden. I'll be your host today. And with me, I have a great guest, Dr. Gabe Pagani, out of Cincinnati, Ohio, interventional spine physician. And super excited to have you here in Kansas City at the Spinal Simplicity headquarters. Thanks for joining us today.
Thank you for inviting me out here.
Yeah. Have you been to the headquarters before?
This is my first time actually ever in Kansas City.
First time in Kansas City?
Yes, sir.
Okay. Barbecue tonight, right?
Yes, sir.
Okay. You have to let me know how it compares to your other barbecue spots as you in your travels. Most people think Kansas City's number one, but we're a little biased, so that's awesome. Get some ribs, get some good beans, so that'll be a good deal. So, and we've got a lab this weekend too. You're going to be help teaching. Mm-hmm. Yeah, that's fantastic. So you have a full weekend here in Kansas City. Glad to have you. Fantastic.
Glad to be here.
Yeah. So we're going to talk about something a little bit unique today with you, which I'm really excited to talk about. Is you're obviously a physician, you see patients all day long, but you've become sort of a patient yourself here recently with your own back pain journey. So how did this start for you, Dr. Pagani, and what are your symptoms? How are you feeling today?
Well, I'm feeling good today.
Yeah.
Thank you for asking. My symptoms are kind of insidious, vague, came on without an obvious precipitating cause as far as I am concerned. And when I started talking about it at work, and just mentioning to people, sometimes trying to take my lead off when I can in between cases. And I actually find that many, many, many people that I work with also have chronic back pain. So it really is an epidemic. People just don't like to talk about it. I guess they don't want to be perceived as whiners or whatnot, or so it's really everywhere. And, I probably started to feel it in the last couple of years. If I think about my past, I had some basketball and soccer and weightlifting injuries, and I remember I threw my back out, quote unquote, but it always just fixed itself. And for whatever reason, just started to kind of grind down on me. The back pain started to become an intermittent thing to a more steady, chronic thing. So to some extent, I always have now some element of back pain. Sitting here, I can pinpoint it. I can feel it. I know it's there. Mm-hmm. It rarely, however, stops me in my track anymore because of some lifestyle changes that I've made. To tell you the truth, I've being smarter about things. Like for instance, so one of the things that'll kill me is like bending forward and holding that position for a long period of time. So like giving my little girls a bath and stuff, I got to be on my knees when I do it, or be in the tub with them. So even loading and unloading the dishwasher, sometimes I even need to be on a knee and just grab it from the sink and the dishwasher back and forth. So I've learned some kind of coping, adapting strategies that way. I also take strength conditioning very, very seriously, and I think that's helped me. I've kind of gotten strong everywhere, and I think my back has more support from the rest of my body now. The interesting thing is that I actually have imaging from before the time I got hurt.
Why do you have imaging from before?
Because when I was an undergrad at Stanford and I needed money for partying, there was a research study going on that I would just basically get paid, and they would scan me and different things. So some of it was functional MRI brain stuff, but some of it was actually spine scans I was getting. And I never got a diagnostic interpretation, but I was curious, and so I asked for a picture once. So I still have like a black and white copy of a mid-sagittal T2 lumbar spine MRI. And I can tell you at that time, I know it's just one cut, but one cut tells you a lot. Yeah. At that time, all the discs were, hydrated, so plump and white, essentially on a T2 sequence. There was no alignment abnormalities. I got an MRI a few years ago, actually, and things are much different.
Is this because you were in pain? You went and got an MRI?
Yeah, I was like, and honestly,
like, what's going on here?
Like every patient out there, I kind of hit the deductible, so I was like, whatever, I'll get a scan. Yeah. Even though I know I'm not going to do anything about it, I'm still want to get it. So I have now a grade 1 spondylolisthesis, L5S1. I have actually bilateral pars fractures at that segment, so spondylolysis, which potentially is congenital. Those things can be congenital as opposed to traumatic. And I did get in like a jet ski crash once, but that's about the biggest trauma I can think of, and I didn't really have any sequelae after that. Yeah. And that's a story we will not get into. There's college in Cabo San Lucas, so that we won't get into any details there.
Yeah.
And I actually also have a severe multifidus muscle atrophy at that segment.
Interesting, yeah.
And now I have modic changes at the L5 S1 level, and the disc is it's lost its height. Certainly, it's desiccated. It's not a severe height loss, probably moderate height loss.
Okay.
So I think putting everything together with my one mid-sagittal MRI slice, my history, I think that I have. Oh, I know I have instability.
Yeah.
I have several things driving it. I have disproportionate multifidus muscle atrophy, so I don't have my muscles firing and locking in and stabilizing my spine.
Mm-hmm.
Part of my posterior arch is incompetent with the pars fracture. And then now, my last scan I was 20, and now this one I was 40. So in the intervening 20 years now, there's been a little shift.
Mm-hmm.
And I don't think the modic changes are causing my pain. I don't think that specific disc is necessarily causing my pain. I think it's just a whole degenerative sequence to begin with. So
yeah.
I think
grade 1, you said, right? Grade 1 spondy?
It's a grade 1, yeah.
Can you feel it at all?
No, and you know what? I actually have never had a flex X, to tell you the truth.
Yeah.
So I don't know if I have what you would call gross instability.
Any translation at all?
Yeah.
Yeah.
I can probably get a flex X someday out of curiosity, but basically, like, I'm living proof of the degenerative cascade. So I think, so in another 20 years, I don't know. I mean, the shift will probably be worse. I may have radiculopathy developing. I may have postural stenosis development. And so the reason why I think I've improved because my back pain used to be worse. I'm now maybe averaging a 2 or 3. It used to be like a 4 to 5. It used to be worse.
Yeah.
And I think my strength training has helped my multifidus come back a little bit online. And, my bony spine, the bones of my spine, I think are not feeling as much pressure.
Yeah.
Because I'm in my day-to-day work because of the muscle gains I've had.
So the load has shifted more. Your muscle's holding on to it more.
It is what it is. Like it's degenerating,
Yeah.
And it's going to continue to slide, and the modic will get worse and the disc will get worse.
Yeah.
But, that's so the big thing about Spinal Simplicity is that the big, what do you want to call this, a paradigm shift or a sea change is that, pain physicians were not thinking about instability.
Yeah.
It was just not in the curriculum, It's basically our curriculum was find just one pain generator, the disc, the facet. And if not one pain generator, if it doesn't work and nothing works, then just try a spinal cord stimulator, try a pump, try something very kind of just palliative, And now we have the ability to fix stability with, like Minuteman, and, restore pain control, restore function. And, the pain physician is now evolving from just simply a palliative care specialist, if you will, like those fancy Band-Aids. And now we're actually able to fix things, to even cure things, and things that we all went to medical school to try to do. And so, so seeing what Spinal Simplicity has done in my practice for my patients and thinking of myself, and I'm in that same continuum that all my patients were in basically 10 years before they saw me. 20 years before they saw me has certainly changed my perspective of spine care and why pathology happens and what to do about it.
Yeah, and I'm sure your own pain, limitations, journey has changed the way you think about your patients, and you can empathize with them at a deeper level now because you're going through basically what a lot of your patients go through. That is so interesting to me. How does that change your conversations in clinic with them?
Oh, I pretty commonly tell them I got back pain, because so for instance, in I work at 2 different hospitals. In one of the hospitals, the only chair in the room, the default chair is a stool without back support, and I do need back support. If I sit without back support, my back will really start hurting. And so I'll joke with the patient. I always say, I can't sit in this chair. It's going to hurt me because of my back pain, and I'll grab another chair. And, I think it helps to build rapport with the patients if you kind of humanize yourself a little bit as a physician. There can be sometimes a power dynamic thing going on, or maybe they had a bad experience with another physician or not comfortable with you. And so I think anything to humanize and level the playing field, and so I'm very candid with my own problems with them. So.
Yeah, absolutely. So as we're talking about instability here, you mentioned that like even you've changed your way in thinking about it, whereas before it was more palliative care. When did that shift happen for you? Was it because the tools were there now, or were you hearing it more from your patient and you were going, man, I wish I had something to help them here. Like, when did that shift for you?
That's good. I think it's both. I mean, now we have the tools. I mean, listen, I'm fairly young in my career, but the pain space is unrecognizable now from when I was a fellow 7, 8 years ago.
Mm-hmm.
It's changed dramatically.
Mm-hmm.
Again, we basically had stim and pump and Vertiflex back then, and mild, and that was basically it as far beyond the bread and butter stuff that's been around since the 90s or earlier.
Mm-hmm.
But now, again, we have tools to really address instability safely, and instability was not part of the curriculum. The spine surgeons have their way of thinking about instability, and the pain physicians never really thought about instability, and now that the specialties are kind of I don't want to, coalescing is a strong word, but they're beginning to kind of embrace one another as far as treatments are concerned. More. I think the pain space is having more of an awareness now, thinking about instability, looking for it, realizing that instability is leading to all these downstream changes in the spine.
Yeah.
That is why. Like, you don't have to scratch your head if your basivertebral nerve ablation in the 70-year-old's not a home run he thought it was going to be, because they have instability too.
Mm-hmm.
So that is why any one individual interventional procedure that targets just one aspect of degeneration, as opposed to the whole degenerative problem, may in some patients not be enough for them.
Right.
And we saw it too, and just in seeing the failures of our other therapies.
Mm-hmm.
So why is a spinal cord stimulator patient not happy now when he was happy all these years? Well, because there's now degenerative, potentially an explanation that I find often. There's now a degenerative problem at play, at another spinal level. That's now the main culprit of the pain. And then if you fix that, then you salvage the stimulator and you salvage the patient. So I think the evolution of the field, combined with just seeing the, I guess, trials and tribulations of my own patients, the successes and the failures, all that kind of click together and, to make me appreciate and think about degeneration on a day-to-day basis.
Yeah. We talked a little bit ago about, not just identifying maybe one pain generator, so you've got, or even an MRI. So you're looking at motic changes, and you might see some fluid in the facets. You might see central canal stenosis. I'm sure a lot of your patients have a lot of that. How do you think about what you treat first, when you treat that? Do you ablate the nerve? Do you fixate? Do you clean out the central canal? Like, what's sort of your thinking in that? Or you do the first, like maybe the least conservative one first? How do you think about it?
A lot of it is tailored to the patient sitting in front of you.
Yeah.
How bad off are they in their lives? How desperate are they for relief? What is their tolerance for risk? What is your tolerance for risk with the patient? Ultimately, and the history is just so essential. And I know sometimes it seems trite to say that, but the history is often overlooked, Just sitting there and shutting up and just stopping and staring at your computer and listening to the patient. Just let them go on and on and on, just a couple of minutes, and then they'll tell you the whole story. That's one of my mentors said, just like, if you just let them, the patient will tell you everything you need to know. You just need to let them.
Right. Just be quiet and listen.
You just need to let them.
Yeah.
So so a lot of the therapies depend on what the patient is describing, like where their pain is, what makes the pain better, what makes the pain worse, and then that'll kind of help you select the part of the spine that's more the culprit.
Yeah.
So I know it's kind of a vague answer, but you got to kind of take what the patient gives you and just make your best guess based on their history, their exam, and the imaging, and what's going to be the best chance for them to get better.
Yeah. If you find there's, we'll just call it a couple of pain generators, would you more often stage those procedures? Do you do them at the same time? Does it kind of depend on the patient?
So,
have you done both, maybe?
Yeah. So that's for reimbursement reasons. Many people are going to stage things, okay? Yeah. Because if you start bundling everything, and then the hospital lose money or whatnot. One of my sites of service, however, I can we don't have that concern about bundling, and I'm actually salaried there. I don't have to worry about RVU. I don't have to worry about this, that. I just do what's right, without all those other distractions. Not that they're irrelevant, but without all those distractions from the doctor-patient relationship. And so yes, I have been comboing, if you will, some of these therapies And probably the biggest combo I will do, as far as frequency, is to in the patients who have postural dependent stenosis, relief and forward flexion, imaging showing central foraminal and or foraminal stenosis, and who have ligamentum hypertrophy, all that. The appropriately selected patient, I will do a minimally invasive lumbar decompression, a mild procedure, followed at the same time with a Minuteman through a lateral approach, so kind of the posterior mild and a lateral Minuteman. And so, why do that? Well, Minuteman is amazing for indirect decompression. It can increase the cross-sectional area of the foramen, central canal, and mild will definitely also create more space there by removing some of the flavum, ligamentum flavum. I found that a lot of my mild patients do well. We'll call them mild-only patients. A lot of the mild-only patients historically have done well, but inevitably, they want more relief. They want to be able to do more. It's almost like you give them a bit of taste of freedom, but they're not free. Now they really want to be free, if that makes any sense. Yeah, I'm now going from walking 10 feet to 200 feet, but I want to, walk without restrictions again. They always kind of want more.
Yeah.
And so for that reason, I believe, combo at direct/indirect decompression in the patients, it minimizes the anesthesia burden and gets them to where they want to go faster.
Yeah, that's interesting too. Is it's one surgery, anesthesia once, patients in the hospital once, rather than staging them. So yeah, that's really good. Okay, we're gonna take a quick break on the serious questions. Got some fun rapid fire questions for you. Didn't talk about this on purpose because I want to get your natural organic reaction. So, okay, we're talking about a sales rep in the OR in your clinic. What's the best sales rep habit you've ever seen that's helped you in your clinic? How have they helped you?
None of them help me.
I love it. Okay, then how about the worst rep habit?
Oh, that's a tough question. I'm pretty easygoing in the OR.
Yeah.
I'm really not a taskmaster. We did have one rep with a laser pointer that would always put the laser pointer at the at the imaging, and it would drive my scrub tech nuts to the point where the scrub tech tried to kick the rep out of the room. That was kind of interesting. So we have a no laser pointer in the OR rule. I think what makes a rep great at being a rep is staying engaged with the case.
Okay.
Sometimes, even if it's not an essential part of the case, you'll see them on their phone or whatever, doing something else, and you're like, you should be part of the case.
Yeah. Yep.
Every single step of the way. And then, especially younger in my career, when I needed redirection because I had less experience with some of the stuff.
Yeah.
Reps were really able to help me with, redirection. Oh, try this, try that, try this, try that. So.
Yeah. Yeah. Just they need to be engaged with you for sure.
Yeah.
Just look at me. Come on, let's go. At least pretend like you're looking. Are you a coffee guy before or after clinic, or what's your go-to drink for the day? What do you like? Energy drink?
Oh, well, that's only for long, long nights. But I'll do an energy drink. Just coffee. I prefer the taste of tea, to tell you the truth.
Okay.
But I need the jolt of the coffee, so.
Yeah, just black Americano,
just
latte.
Straight black coffee. Yeah, I have my thermos, and I'll drink it before noon, and then I'll probably fill it halfway with some more, and then try not to overdo it because otherwise I might mess my sleep up. So.
Yeah. Okay, outside of work, what's your go-to fun hobby? What are you into these days? What do you like to do?
Well, I enjoy weightlifting a lot. That's like I told you, I think it's really helped my back, so I'm kind of addicted to it. I think it's my medicine. So I do that like 5 days a week, and then I got a 6-year-old and a 4-year-old. So if I have too many other hobbies, my wife might leave me. So
you got to take care of yourself and be a dad.
Basically, yeah. And, I grew up in Cincinnati, and I live there, and we have a robust circle of friends there. So we, even from high school, even some people that have stayed around. So
Reds, Bengals.
Unfortunately, both.
Oh, man.
Unfortunately, both. For the Bengals this year, it was terrible. So I really checked out of the NFL this year. I know Kansas City has checked out too of the NFL a little bit this year.
This year was a bad year.
It was
for both teams.
it was a bad year for both.
You guys go to games much? Do you guys get to games or just watch them on TV?
No, just on TV.
Yeah.
I know I still haven't seen Joe Burrow play. I know. I should.
You gotta get to a game.
I should someday.
Yeah. You still watch Stanford?
Nope, they're pretty bad at all the sports.
Yeah.
I like FC Cincinnati, believe it or not, Major League Soccer. I think
fun.
KC's got a good team too.
Yeah, Sporting KC. Yeah, we're kind of a soccer hub around here.
Yeah, I played soccer in high school and everything, so I enjoy
Yeah, we've got the World Cup coming this summer here. We got some games.
I know.
Any matches in Cincinnati?
Well, no, actually, and even Chicago got snubbed. Can you believe this? So Kansas City got the Midwest glory over Chicago, even so.
Yeah, you can make it down here then in the summer to come watch a couple
well,
matches.
So my family's from Argentina, so I have the team I care the most about in life is the Argentine national soccer team.
They're practicing here in Kansas City. I actually read that the other day. You should come. That'd be fun.
Yeah.
Yeah, that'd be really fun.
I've seen Messi play twice in my life. This is the last chance.
Have you really?
This is the last chance I get to see him play. So.
Did you go down to Miami and see him play down there?
So Miami came to Cincinnati in the playoffs. So I saw him there, and then I saw him play once for the Argentine national team against Colombia in the Copa America final in Miami. I went there.
Oh, that is fun.
Yeah.
Cool. Okay. Well, good stuff. All right. Fun questions. Let's get back to the serious ones, I guess.
Okay.
So that's more fun. But okay, I do want to circle back to the instability conversation for just a moment, and I want to hear from you, like imaging specifically. So you mentioned flexion extension, obviously axial cut MRIs. What are you looking for in instability that you would say, obviously in the clinic as well, but on an imaging standpoint, like what is like the go-to fluid end facets, flexion extension? What are you looking for to diagnose instability?
You know, it's funny. I remember thinking, and I'm a neurologist. I remember thinking during neurology residency, like, why is spine surgeon getting flex X-rays? This is the dumbest thing in the world. Just get an MRI. And I never understood. I never understood until, again, we started thinking about instability because now we have a way to treat instability. So it's interesting to question, I guess, the dogma of your former years. You know, and that was one of my dogmas. Flex X is dumb. You know, now I realize that Flex X is essential, and working up the patients who have, you know, postural dependent stenosis in particular. The trouble is that usually the only instability that is ever specifically commented on by radiology is a translational instability. That's it. Because I guess their teaching is that that's the only instability that matters, I think, because that's the only thing they ever comment on. So I think that's part of their teaching. And maybe that's because historically spine surgery only really was focusing on that. I don't know why it is. But they'll only talk about a translational instability. However, there is sagittal plane instability that is, I think, the most common cause. You know, thinking about the instability I've picked up in my practice, sagittal plane or angular instability is overwhelmingly the most common. And it might be a tie between, for second place, between the frank translational instability and, you know, vertical instability or dynamic, you know, disc height loss on Flex X. So those are all crucial to look for. However, as actually Dr. Falowski taught me, is that you can have instability without any of those findings, and that's exactly what you're saying. Micromotion instability as far as a facet fluid signal increase in the facet joints. And sometimes that's like your only real example of instability. Again, I'm a big believer in the multifidus atrophy being associated with back pain, and multifidus atrophy is like in almost every scan I look at, and so in my mind I consider that a form of instability. It's just not really widely appreciated in the space yet, but that's a kind of instability that I'll also comment on too.
Yeah, and now I know you've got the tool to be able to help those patients, and we were actually talking with Dr. Rasul earlier today, even like that patient that we call like the in-between, right? The benignly neglected patient that maybe the conservative care hasn't helped as much, but they're probably not a candidate for like a bigger surgery, or the patient, you know, elects not to have a bigger surgery. And so I know you have those tools in your toolbox now to be able to help a patient that has that micromotion or angular or vertical instability. So yeah, that's great. When did you start getting flexion extension? Was that like the past couple of years, 3 years?
Yeah. Oh, really? Only with Minuteman adoption.
Yeah.
That's the only time. Yeah.
Yeah, because then
I realized that
you have something to help them.
like yeah, there's a lot more subtle examples of instability that is associated with, of course, you know, spinal stenosis and neurogenic claudication.
Yeah. Well, very good. Well, let's talk a minute about your SI joint fusion journey. So obviously injections started, I don't know if you did any RFA, allografts. So tell me about like when you started looking at the SI joint as a pain generator for your patients, and what did you start with? Kind of what are you doing now? What's that journey been like for you?
So I'm biased. I think I went to a very good training program and fellowship that, you know, not only just stressing procedures, you know, but stressing clinically evaluating patients, working them up. And so SI pain has always been on my radar. You hear stories about some people never look for it. Some people, they just do epidurals and RFA and then stim, and they skip SI evaluation entirely, and it's not rare. And, it's maybe 30% of back pain is SI pain. I think a lot of reasons why there are failed spinal cord stimulators out there is because it's actually SI pain, even though, they have screws here and screws there. No one, they need an SI joint treatment. They don't need a stimulator. So for whatever reason, it's kind of under the radar. Even a lot of spine surgeons don't really look at it, don't really think about it, and don't even offer SI fusion. I mean, they'll do much more complex spine surgery, but won't even think about the SI joint. So for reasons unknown to me, it's kind of in this neglected category. So I look for it. So I don't think I miss very much of it. But for whatever reason, corticosteroid in the SI joint just does not last as long as it does in other parts of the body. I don't know why, but it's rare if I have somebody getting more than 2 months.
Yeah.
With an SI joint steroid. In my state of Ohio, ablation has been outlawed or whatever. You can't do SI joint ablation, but for a while we were doing a lot of it. Outcomes are okay. For whatever reason, it's probably because the nerve is in a very unpredictable location, so that the longevity is never quite as good in my hands as facet joint denervation. So, 4 to 6 months might have been an average, I think. Every once in a while you'll get a home run, but they weren't common. The people that come once a year, once every 2 years, weren't very common. And so before, I guess there was a renaissance in SI fusion because SI fusion is not new. Then we would dabble with SI joint stim. So I do have a patient where I parked some spinal cord stimulator leads next to the SI joint, and so that was a kind of a phase of treatment. And now some of the PNS systems try to do the same thing. Focusing on actual SI joint arthrodesis procedures, I did start with cortical allograft. And why I started with cortical allograft was because it just seemed like you're dipping your toe in the water, and it just seemed like a less invasive. It seemed like it. Then a lateral approach, it's not hardware, it's just a piece of bone. Felt like it would be... And a lot of the pain, at that time, a lot of the kind of pain leaders in the field were also involved in promoting literature with cortical allografts. People I know and look up to. So I did many of those, 50, 60, I don't know, maybe, of those. And most people did well. However, I thought that the failure rate was too high for me to be satisfied with it as the way to treat the SI joint, and maybe 20% failure rate or something. And what I mean by failure rate is that people would have relief and then they wouldn't. So, and then we go looking, why don't you have relief? I have never actually seen a cortical allograft have evidence of fusion when I've gone looking. And I don't routinely look for it, okay? So it could be that those 80% of people, well, there was fusion. But in those 20% that were not happy, not one of them was fused. And, allowing sufficient time, year. And sometimes, unfortunately, my allografts were not in the sacroiliac joint at all, despite being pretty meticulous with the surgery. And I think the problem is that the system I was using, and most systems out there, even though they do have a guide pin that goes in the SI joint, there's several problems, especially if you're kind of rough. The guide pin can go in the joint and then can leave the joint. That's problem one. Problem two is that even though you've accessed the joint with the guide pin, with most systems you then remove the guide pin and then you put a much bigger decorticating kind of brooch device that you mallet in. And, I mean, it's a finger cross that it stays in the joint. So for those two reasons, especially having an implant not in the joint where I swore it was, even looking at the fluoro and the OR, and it looks on the fluoro like it's in a joint, and then all of a sudden it's not. And that was not acceptable to me, So that's why I switched to a lateral system. Yeah, Liberty is what I use. And technically the lateral approach is kind of the gold standard in SI fusion.
The patients have done well.
Yes, very well. Now, I tell my patients, though, I'm going to tell you this, out of all the surgeries I do, this one hurts the most. It does. There is post-op pain, and you just have to prep them for it, because when you go through, gluteus medius, you use that muscle every time you take a step, every time you walk. So you just have to prep the patient for it, but it is worth it. The relief they get is usually profound and fairly rapid after that stormy period, but the first 2 times maybe I didn't walk the patient through that, and they came in the clinic saying, "My God, doc, what did you do to me?" So now I always prep them, and I say, "Hey, you gotta do ice, you gotta do chair squats. It's gonna be a little bit rough for a little bit, and you're not gonna like me for a little bit, and then you're gonna like me again."
Yeah, yeah, absolutely. So initial post-op pain, and they end up getting better down the line. Yeah. Well, Dr. Pagani, it's been a pleasure. Thank you for sharing your own story about really your own pain, and then kind of how you've adopted these therapies to help your patients. But then also you've been able to be more empathetic with them because of kind of what you've suffered through. One last question for you, as a physician that might be listening to this, and maybe they're nervous or apprehensive about using some product like Minuteman Liberty, or any, I'll just call them an intervention that's not conservative. What would you tell them to help maybe ease their fear? Because at one point, 4 or 5 years ago, put it in your shoes, 6, 7 years ago, what would you tell them to say, hey, this has been my journey, and here's how I overcame those fears?
Well, if what you're doing to the patient in front of you is not working, you got to try something else, And ultimately, everything comes down to the patient. So if I continue to utilize the tools I had in fellowship as my only tools, there would be a lot of patients that I would not be able to help to the same degree I'm helping now. So you have to keep an open mind, but a skeptical mind, okay? You got to keep an open mind. The pain field is changing rapidly. I think most of it's good. Maybe not all of it's good, though. And, so you have to do your due diligence and think about the technology, think about the anatomy, think about the underlying studies, but I think just the days of pills and stim and pump as your only plays when you have a refractory patient are gone. Now we have much more elegant, refined therapies. Now pain physicians can fix problems instead of Band-Aid them, basically. And so just keep an open mind. It's so easy, even for me, it's so easy to fall into your habits and your patterns and be like, this is the way it is, and A must lead to B. But, there's so much about the body and about pain and about spine. There's so much we don't understand. We only understand a sliver of what's going on. And we may think we know a lot, but we really don't. Just keep an open mind and listen to your patients and, seek out some of these alternative technologies and get trained on them, learn about them, see if it's right for you and your patients.
Well said, Dr. Pagani. Thank you so much for joining us today. Really appreciate your time.
Thank you, Parker. Always good to be here.
Yeah. Thanks for joining the MedTech Insider. We will see you next time.
This podcast has been financially supported by Spinal Simplicity. The content is for informational purposes only and should not be relied upon as medical advice. The views, opinions, and information provided by participants are their own and may not reflect those of Spinal Simplicity. Healthcare professionals must exercise independent medical judgment, and patients should always consult with a qualified healthcare professional regarding medical decisions. Finally, the healthcare industry is constantly changing, and neither Spinal Simplicity nor the participants can guarantee the accuracy, completeness, or timeliness of the information provided in this podcast.